Good morning. Thanks for coming in this morning to hear a little bit about evaluation and treatment of cognitive communication impairments and disorders. I am Michael Cruz, and I won't read all of that, but basically born and raised in Montana and came over here to the University of Montana area for college and decided to stay here for work because I just love this area. I worked in the hospital for several years and then for a private practice speech therapist, and then I decided to go out on my own in 2007 and built A Matter of Communication, which is my business, and then collaborated with some other OT, PT, speech therapists to form Integrated Therapy Works. And this previous October, we just moved into a brand new building, and we've grown and just have a fabulous group of therapists that work integratively together to serve the community here. I have just always had a passion for helping people. When I got into the hospital setting, I first thought I wanted to work with kids, but then when I started working with adults who had different levels of cognitive and communication impairments, that kind of became my passion, and so I've kind of built that. Got to a point where I had a wait list that I could not manage and was overwhelmed by that, and talked to Jill Olson from Peak Performance at one point, and she said that her daughter was just graduating from college, and what a treat that has worked out to be. I'm just so glad that Josilyn joined the team, and she's such an asset to the clients that she sees and to our business. So I will let her introduce herself.
Thanks, Michael. Hi everyone, my name is Josilyn Ovenell, and I am a sixth-generation Missoulian. I was born and raised in this beautiful city. I received my bachelor's degree in communication sciences and disorders here at the University of Montana, and then I went on to get my master's in speech-language pathology at Pacific University, which is more of a medically focused program that's just right outside of Portland. I've been working at Integrated Therapy Works for about 3 years now, and I'm specializing primarily in cognitive communication disorders throughout the entire lifespan. This passion of mine really started when I was around 18 years old. As you may have seen in my bio, I mentioned that I have personal experience with brain injuries. And so just to share a little bit of my story with you guys, when I was 18 years old, I had a hemorrhagic stroke in the right frontal and parietal lobes of my brain, and ended up having to go in for an emergency craniotomy. And as a result, I ended up having to take off my freshman year of college to undergo intensive rehabilitation, which included speech therapy, occupational therapy, and physical therapy. And it was really my speech therapist that got to determine when and if I would ever be ready to go to college. So needless to say, she had a very instrumental role in my life, so much so that I decided to go into this career, really just so that I could also walk alongside other stroke survivors or individuals struggling with cognitive communication challenges. So throughout this presentation today, I'm going to be providing you all with two different perspectives. One being what it's like being on the receiving end of the therapeutic process as the patient, and two, from the clinician point of view. So to jump on in for the...
A couple of things we wanted to check in on first. Hopefully the PowerPoint was uploaded and also a folder of resources. If that was not and you need that, we have our contact information and we would be happy to send you that information.
Also great.
Right, so over here is
as
a
well
folder.
if you guys want to look at any of them.
Just includes some resources that we've used to help with the education portion with our clients to help them better understand what's going on and improve their metacognitive awareness skills. I did want to find out a little bit about the audience that we have. How many of you work in the school setting? Okay, and how many in a private practice setting?
I think most of us are students.
Oh, most are students, okay. So is anyone out there working in the field yet, or all students? Okay, perfect. Okay, so some of you, I know at least one of my students is in the audience, and so have gotten some of this experience. How many of you have been in a setting for any type of hours internship that you've been in the cognitive communication arena? Okay, so several. Perfect. So some of this will be familiar to you. We just kind of want to share a bit about what we typically do with our clients, but know that this is certainly not an exhaustive list of the treatment tools that we use or how we work with our clients or the testing, but just kind of our favorites, things that we found that work really well to meet their needs. So our learning objectives today will be to provide cognitive, physical, behavioral, and emotional consequences following acquired brain injury, that you should be able to identify the red flags, both for adults and kids, that you'll be able to name at least one cognitive communication assessment for kids and one for adults, and at least 2 of the evidence-based practice treatment strategies that we use for children and also for adults.
All right, so a lot of what we're going to be talking today falls under the umbrella of acquired brain injury. So we want to dive in a little more into that so you guys have a clear understanding of what all that entails. So an acquired brain injury is a brain injury that occurs after birth. So it's not something you're born with, it's something that you acquire. And it can be broken down into 2 different categories. First category is a non-traumatic brain injury, and that is caused by damage to the brain by internal factors, so something going on inside the brain. That can include things like a stroke, a tumor, meningitis, encephalitis, seizures, electric shock, infectious diseases, metabolic disorders, neurotoxic poisoning, so carbon monoxide or lead exposure, lack of oxygen, so hypoxic or anoxic brain injuries, drug overdose, and then also COVID. We have been seeing an influx in COVID clients that are being referred to us later on. And there's been a lot of research that's shown that COVID can create an increase in inflammation and also an increase in blood clotting, which can then heighten a person's risk for strokes. So we're seeing a lot more cognitive challenges following COVID long hauler, kind of what we've been referring to it as. And then the other category is traumatic brain injury, or TBI. And that is caused by external factors, which is usually a violent blow to the head. So those include things like falls, assaults, motor vehicle accidents, and we usually see a lot of whiplash or concussions with those. Okay, can you hear me now? Motor vehicle accidents, which usually we'll see a lot of whiplash or concussions, sports and recreation injuries, abusive head trauma, or which is now being referred to as shaken baby, or other way around. Shaken baby syndrome is now being referred to as abusive head trauma. Gunshot wounds, workplace injuries, domestic violence, and military action through blast injuries.
It's important to talk a little bit about the incidence and prevalence so that we know where these clients are coming from, and that can help with education and prevention. So it's estimated that 2.5 million traumatic brain injuries occur annually in the United States, and of those, about 75% are typically in the mild TBI range. The incidents, or individuals who have a traumatic brain injury are 2 times more likely to die as opposed to someone who hasn't had a brain injury, and the life expectancy just by having had a brain injury is decreased by 7 years. And as we talk about some of the factors that are affected, attention, memory, those kinds of things, you'll begin to see why that is the case. Approximately 640,000 pediatric TBIs that go to the emergency department are noted, and obviously when you've got abusive head trauma, there's a high incidence likely that they're just not even coming to the ER, so that number is probably significantly higher. The highest incidence of traumatic brain injury in children is in the 0 to 4 age group, and the second highest is in the 15 to 19-year-old, and the most common cause is due to a motor vehicle accident. This abusive head trauma is the most common cause of children with TBI, and it's in that 0 to 5 age group is the highest number. TBI caused by abusive head trauma, 58% are typically boys and 42% are girls, and 75 to 80%, it's estimated, have long-term disabilities from abusive head trauma as children. And if you think about the fact that many of those don't make it to the ER and they're probably not even known, then those are kids that we're getting in the schools that are probably having behavior problems and difficulty learning, and it's not even acknowledged that there was any kind of a head trauma when they were younger. And so we have to learn the red flags so that we can point out and figure out what's going on with some of these kiddos. I'm not going to go over this one in detail, but just kind of want to lay out that there's a primary and secondary injury often with traumatic brain injury. So you've got the primary accident, which is whatever the blow was to the head, if they fell and hit the back of their head, or if they were in a car accident and had both coup and contra coup damage from hitting the front of their brain and the back of their brain and their skull. But then there's also this secondary injury cascade of things that can happen, that there's tissue damage and there's metabolic imbalances, and all that can lead to cell death. That's often not even noted until years later. And so we have to be aware of that, so that when clients come in, we often get them years after their accident and they've got challenges and impairments that they're working through that they don't even associate with the brain injury. But when we go back to this, we can see that it has to do with that secondary injury that's going on. The risk of multiple TBIs is also an important factor for us to be aware of. There's the initial injury, and then you're 3 times more likely to get a second brain injury if you've had a first. And if you've had a couple of them, you're 8 times more likely to get a third, fourth, and subsequent head injury. And again, because of the impaired attention, memory, awareness, ability to consider relevant and irrelevant information, all of that factors in and puts people more at risk of having additional head injuries after they've had a couple.
Okay, so can you hear me clearly now? Okay. So some of the primary consequences that we see following an acquired brain injury can be broken down into 3 different categories. So the first one being cognitive. So executive dysfunction. So that refers to the executive functioning skills in the frontal lobe of your brain. So meaning dysfunction, they're not working properly. So we'll see a lot of poor planning, difficulty problem solving, difficulty organizing, reasoning, initiating, or making decisions. We'll also see difficulty processing both expressive and receptive language. So they may have difficulty following along in conversations or difficulty comprehending written content. You may also see some decreased insight and awareness into their challenges. They might not know that they even exist or recognize that there has been a change. Also decreases in their memory, attention, and speed of processing. And then for the physical, which we don't work as much with, this involves more of like the headaches, the cognitive and physical fatigue, which we work a lot with the cognitive fatigue. And a lot with the visual spatial difficulties as well, that attention to detail. But the vertigo, the nausea, the sensory loss, the hearing loss, the tinnitus or tinnitus, everyone pronounces it differently, epilepsy, changes in sexual drive, sleep disturbances, a lot of neck, head, and back pain, and then decreases in mobility. So if we see a lot of those physical challenges, oftentimes we will refer to a physical therapist, which we'll kind of dive a little more into here in a moment. And then the emotional and behavioral challenges. So we'll see a lot of lowered tolerance levels. They may be more easily angered or frustrated. They might have more frequent temper outbursts or rapid mood swings. They may also experience some emotional lability, so they might be crying more easily or laughing at inappropriate situations. We'll also see some emotional flattening, so maybe loss of facial expressions or apathy, reduced motivation and drive, disinhibition, impulsiveness, lack of filter, and then also changes in mood, anxiety, or depression, which again, if we see some of those things, we probably refer more out to a counselor.
We'll talk a little bit about the red flags that we want to be able to look for in different settings, and some of this would be maybe classroom teachers, it could be parents, it could be daycare providers, doctors even, to recognize these and know then when to refer is what we'll discuss next. So in children, especially in the classrooms, we're going to want to look for difficulty following directions, emotional dysregulation, often that they blow up at very small things and are not able to regulate their emotions well. Disorganized backpacks is a classic thing that with our kids you almost will always find a completed homework assignment that is done, but weeks ago it should have been turned in, and there it is crumpled in the bottom of the backpack. That's pretty classic for these kids. Losing assignments or turning them in late, not being able to track when things are due or verbalize back what they need to be doing in their classes. So falling behind on their assignments and school responsibilities or home responsibilities as well. Difficulty socially. Because of the cognitive communication impairments, they often don't pick up on cues, and so they end up having miscommunications and challenges with developing and keeping friendships. Avoidance behaviors often come from that because they might be cognitively overwhelmed, and so they're avoiding situations, or they just don't quite know how to navigate them. And so we need to watch for those red flags in kids to know when to refer and how to help them.
And then some of the main red flags that we'll see in adults is difficulty following along in conversations or filtering out information. So they might completely misinterpret a homework assignment or an email, or not even recall a conversation that they had. Frequently misplacing things and forgetfulness, might be frequently losing their wallet or can't find their keys around the house. Decreased stamina and endurance. Quick to get fatigued. They might overbook themselves or miss appointments. I can't tell you how many times I've had clients tell me that they've scheduled another appointment at the same time as they have speech therapy, even though speech therapy is the same time every week. They also have lower tolerance or threshold levels, so changes again in their mood stability. Repetitive question asking, again, that kind of goes back to the conversational recall. Might not remember a conversation they just had and keep asking you the same question over and over again. Difficulty meeting deadlines or paying bills on time. That's kind of a classic one we work on adults, is managing their bills, making sure they're not getting the late fees, trying to set them up with some automatic bill paying systems. Also, several unfinished projects. That's a big one we see as well. This can be interpreted and really frustrating for spouses or family members. They may see it as, the person is just procrastinating or being lazy, but really they're having a difficult time following through and completing tasks. And then also similar to that of children, we see a lot of avoidance in social gatherings. It tends to be just too overstimulating for them, that they may just completely avoid it altogether. So knowing when to refer, I think, is a really important skill as a speech pathologist and other healthcare professions as well. But when we are given a client with acquired brain injury, whether it's a child or adult, the optimal team would include a speech pathologist, a physical therapist if there's challenges in their vestibular ocular motor systems, if they're having some neck and back pain, if they're having headache, nausea, vertigo. Those are all things that a physical therapist that specializes specifically in the concussion treatment could help with. Neurologist, a neuropsychologist, neurofeedback, a primary doctor, counselor, classroom teacher, and IEP team if the kid is in school. And I kind of touched already on when to refer to a physical therapist. And then also if we're noticing challenges in their mood, depression, anxiety, if there's any suicidal ideation or anything like that, that would be the time to refer to a counselor.
So the World Health Organization International Classification of Functioning is a resource that we use to help guide in determining that therapy is necessary, because they then qualify as either having a handicapping condition, an impairment, or a disability. And we target problems with okay. We target looking at what the body function is that's impaired, and for us that would be, of course, the head, brain, and then what the activity limitations are in their life. So they're maybe not able to engage full-time in work, so they have to do part-time, or they have to have modified schedules because they just can't manage the activity level, and the participation restrictions, things that they're restricted in doing. They maybe are not able to engage, as Josilyn had said, in the types of social activities that they did before, because all of their effort is put on doing the work or taking care of their home or their children, and so they're restricted in how they can participate in life following the brain injury. We'll look at environmental factors, things that we can possibly change to improve their functioning, and then personal factors. For example, if they're married or divorced or single, those all can impact people individually. If they have children, if they have a lot of support or don't have much support in their life, that can make a big difference in the trajectory of their treatment as well.
Okay, so some of the primary skills that we are measuring when we are doing a cognitive communication assessment or testing looks at a lot. And I'm sure a lot of you have heard the classic, oh, you're a speech therapist, you just work on speech. Well, believe it or not, there's a lot more skills that we target as well. So with cognitive communication, that tends to involve memory, attention, executive functions, the visual spatial skills, looking more at that attention to detail and their spatial awareness, written expression, reading comprehension, speech, language, fluency and voice, and then also swallowing.
For the cognitive communication assessment process when we work with children, as we do with all, we would start out with a case history. We're going to gather information, get records from parents, doctors, teachers, and some of the identifying factors that we need to look at that impact how they are going to proceed in therapy and what tests we're going to select would be looking at the support system that they have, their educational level, age factor, time from treatment, when they started treatment versus when they had the accident. That's a big one. And as we talked about with the abusive head trauma, sometimes it's not even known that they have a brain injury. And so when we get to talking, we can figure out some things that have happened. Sometimes it's not even abusive head trauma, but they will say, oh gosh, yeah, they fell off their bike when they were 5 and they were loopy for a few days, had headaches and whatnot, but then we didn't think anything of it. And so trying to look back into that history and ask the right questions, because we almost always can find some type of traumatic brain injury that occurred with the clients that we tend to get referred. Sleep disturbances, motivation, and then comorbidity is also a big factor that we look at. Oftentimes with the children, we'll see other diagnosis of attention deficit disorder or oppositional defiant, reactive attachment.
ADHD.
Yeah, ADHD, didn't I say that one?
Oh, sorry.
And then looking at those comorbidities with mental health issues as well, especially when we look at going forward with what these kids have been through in the past couple of years and how it's impacted their education. So standardized tests that we would look at, we're obviously either going to assess or we'll get information that's already been done maybe in the schools to look at the expressive and receptive communication through the clinical assessment of articulation and phonology, the Rossetti for the little kiddos, the test of integrated language and learning, which is the TILS, the receptive expressive social communication assessment, and the test of intensive information processing skills. That's one that I really like, and I'm not sure how many of you are familiar with that, but we have that on the table, and I think it's a good resource to differentiate between visual versus auditory processing. And the self, those are ones that we looked at just for the expressive and receptive communication, but then specifically for looking at their executive functioning skills, a couple of our favorites that we feel provide us with the best information to decide on goals and move forward would be the pediatric test of brain injury, which is the PTBI, and I'll go into that more in detail in a bit, but it looks at memory, attention, language, visual, spatial, and executive function skills. The executive functions test, which looks at working memory, delayed memory, attention. That's a test that we often give because it gives us some insightful information, but we feel like the standardized portion of it, it just never seems to match up. They almost always fall within normal limits, even though we know they have significant challenges. And so we struggle with that one, and we're still looking to find a better resource for that kind of middle age group of kids there. And then the functional assessment of verbal, reasoning, and executive strategies, the student version, which is the S favors. Again, I'll talk about that more in depth because that's one of them that we feel is the most valid and reliable test to show the challenges that they have. But those are kind of the tests that we would primarily use to look at their executive function and high-level cognitive communication skills in children.
All right, so now jumping into the cognitive communication assessments for adults. So it looks somewhat similar to that of children. However, with adults, there tends to be a lot more medical documentation involved. So we would collect all of those records first, and then again, we would identify the factors that are impacting their brain health recovery. So there's been a lot of research that has shown there are factors that can speed up one's recovery, and there's also factors that can slow down or kind of complicate or prolong their recovery. So we know that a good support system, we know that motivation, we know that time of treatment, how long has it been since their brain injury, are they coming to see us? Is it right away? Is it 4 years? That's going to play a big difference as well. Those are all things that could help speed up the process. However, there's also a lot of things that can slow that down. So we know that loss of consciousness tends to indicate it was a more severe brain injury, indicating it's probably going to be a little more complicated, it's going to be more slowed and prolonged recovery. We know that if we see history of pre-existing mental health issues, so did they have anxiety or depression or other mental health related issues prior to their brain injury? If they did, again, that's going to tell us it's probably going to be a longer recovery road than without. Motivation, too, is a really important one for our adults. Oftentimes we will get clients referred to us that don't want to be there, and it's usually from a spouse or a family member. And so they'll come to us and they'll be like, oh, I don't have a problem, I don't need to be here. And so if they don't recognize that there's an issue, if they have no motivation to improve, then there's only so much we can do as a speech pathologist as well. So that's a really important factor that we always like to address prior to initiating any sort of treatment. And then also their prior level of independence. How highly functioning were they before the brain injury? Did they have a pretty successful job before? Are they wanting to return to that successful job? Because that's going to be a big impact too on the treatment that we do. If they had a really high successful job, that's going to require a lot more highly functioning skills versus somebody that had more low-end job, they wouldn't need to reach that same level. So then the primary standardized testing that we use is the FAVORS, but the adult version. So we'll dive more in depth into those specific assessments here in a moment. We also do the cognitive communication checklist for acquired brain injuries. So that's a checklist that they can fill out that looks at all the different aspects of cognitive communication skills and has them identify which ones they think has been impacted. We also do the repeatable battery for the assessment of neuropsychological status, or the RBANS. That looks more at attention and memory. We're going to dive more into that one here too in a moment. And then the alpha, that's a really, really good one that looks at 10 different language-related activities that are very functional. So that's things like, are they able to count money? Are they able to balance a checkbook? Are they able to address an envelope? Tell time? Are they able to read instructions? All of those skills that you need to be able to do on a daily basis that can often be impacted from a brain injury. The cognitive linguistic quick test is another great one, especially the trail making or the clock drawing subtests. Those are great for our dementia clients. The discourse comprehension test is another good one. The manual for the comprehension assessment of perspective memory, test of word finding, and then for our adults with aphasia, we'll either use the Boston naming or the Western aphasia battery.
Because I can see better with the screen. So Jocelyn's going to point out or hold up some of the information so that you can see them, and we have all these materials up here. So during the break, we welcome you to come up and take a look at some of these assessments if you're not familiar with them, and or feel free to ask us questions about any of them. The pediatric test of brain injury goes from 6 years old up to, I forgot to check what the end is, but through, I think, like maybe even 18. But it's kind of hits those younger ages where a lot of tests don't. They kind of separate it into three areas. The constrained skills, those are skills that develop early in childhood, and so they're less likely to be impacted by anything once they've developed. So that would be orientation, naming, and following simple commands. So learning their name, where they live, that kind of information can be impacted by a pretty significant injury, but typically those that have mild brain injuries, those constrained skills are not going to be impacted as much. The unconstrained skills are skills that develop across a wider age span in their academic years, and it requires organization and integration of abilities across the cognitive and linguistic domains. So it's the higher level language skills and tasks that require the cognitive processes such as searching memory, recalling, organizing information, and the subtests that look at that are broken up into 3 different areas. They have the Factor 1 skills that are developmental language abilities for meeting the curricular cognitive linguistic demands, and that would be like story retelling, immediate, story retelling delayed, and then it has a subtest called yes, no, maybe. And if you're not familiar with that, basically the student sees a passage that's left in front of them, so they don't have to remember it. They take the memory component out of that, but they are read the passage first and then asked questions, and they either answer yes, that it's correct and the information is in the passage that tells them it's accurate, no, that that's not accurate, or maybe, meaning there's not enough information in the passage to tell. So for example, one of them is, what's it say, one morning, Susan missed the school bus. She thought she would be late for school, but her mother got her there on time. And the yes, no, the maybe question says, was it raining that day? Maybe, we don't know for sure. And so that requires kind of those higher level skills to be able to process that information and determine the relevant information in that passage. Obviously, they have to be able to read a little bit at least to be able to do this test, although we do read it first to them. Factor 2 skills would be the complex cognitive linguistic processes that are likely to be impacted more by a brain injury. So that would be the what goes together subtest, and again, the information is left up in front of them, but it would be 3 words, for example, dog, cat, bone, and you ask them what 2 words go together, and they may say dog and cat. Why? Because they're animals. What other 2 words could go together? And they say dog and bone because dogs like to chew on bones. So it gets more complex as it goes along in the subtest, and that requires definitely more higher level cognitive skills to be able to cognitively be flexible and shift set between the 2 different words that could belong together and why. And then picture recall, they're shown a picture of this little fellow here, and I guess online you might not be able to see that as well, but they're asked questions of naming, like pointing to the shoes and the skateboard wheels and the star on his chest, and they have to name all those, and then later in the test they're asked to draw that picture in as much detail as they can, and they're scored on whether or not they get the majority of those specific items that were asked in the naming portion of it. So that's the picture recall. Whereas the naming part is over here in this constrained skills. Once they've learned what shoes or wheels are, they're not likely to forget that with a milder brain injury, but the recall of that information to draw that picture later is impacted. Factor 3 skills would be attention and immediate memory, and that's the digit span. We're all pretty familiar with that because that's in a lot of tests that we do, basically just strings of numbers that get longer and they have to repeat back those numbers in order. And that is another area that can be significantly impacted by brain injury because the attention and memory are some of those executive function skills that are very often impacted. Skills that reflect complex abilities, they're related to the factors 1 through 3. That would be the subtest for word fluency. In 1 minute, name as many animals as you can. In 1 minute, name as many words that start with the letter M as you can. And we'll see those same kinds of word fluency subtests in the favors and S favors that we'll talk about as well. And that's very often impacted when someone has a brain injury. It's pretty interesting to watch that Oftentimes they'll name a few right away, and then they literally just get blocked and sit there for the rest of the minute and can't come up with any other items. And our adults especially will be very flustered by that because they realize, and they're like, oh, I know more animals, I can't come up with any more. And so that's a frustrating thing, and we can see how functionally that impacts them when they're sitting in a meeting and they're supposed to generate ideas, or they're asked a question and they're supposed to problem solve, and suddenly it's like that. Car flooding is the way I talk about it a lot, although the younger folks probably don't even know what that means. But it used to be that a car would flood sometimes, and then you just had to wait 15 or 20 minutes and then it would start up again. Or I also use the analogy of an electric, blowing a fuse, right? You turn too many things on, too many appliances, and you blow a fuse. You can't just turn the lights on, they're not gonna work. You're gonna have to shut things off, go flip the breaker, come back, and then start again, and not do the same thing that you did before. So you're gonna have to adjust something and maybe not turn on the blow dryer when the vacuum is running. You know, so they seem to recognize those analogies as being when they get cognitively overwhelmed. So the what goes together, I already talked about that, but they place that into the area that it requires very high level skills, and those are definitely impacted by brain injury.
It's right there.
So I'm going to talk about the favors and the S favors. The favors is the adult version, and the S favors is the student version. The student version goes from 12 years old up to 18. And both of these were developed by Sheila McDonald in Canada, and I feel like it is the best resource and assessment tool that we have to test these high-level cognitive communication impairments, and very functional. Whereas when students go and get neuropsych testing, they look at a discrete skill one at a time. This favors test, and S favors, looks at the functional skills combining reading comprehension and auditory comprehension and memory and attention all at the same time, and so it's much more functional, and there's research to back that. So there's 4 tasks in each of these. For the task 1 of both the favors and the S favors, they are planning an event for a 7-year-old boy. So you provide them with these 2 sheets of activities that they could do, and they read a passage of information that they have to decide. This is a 7-year-old boy. You can't take him on a Tuesday or Thursday, but maybe you can go on Sunday. You have a vacation in May, so you need to take him before that. You only have $30. So there's lots of details and information that they need to read from the passage, and then go over to the events on the newspaper sheets and decide what would be the most appropriate one to choose. And then we ask them some follow-up questions, such as what were the 5 most important facts that you had to remember, and what would you do if this changed, and now name, in 1 minute, name as many places that you and a friend could go that you can think of. And so we follow up with each task with some questions, and through that gather a lot of information about those executive function and high-level communication skills. Task 2, the scheduling task. This one is in the S favors version. You're scheduling a school day. The kids are scheduling a day that they would have at school. So there's things like, you've got a math exam on Wednesday, you need to study for it before then. You have an essay that's due on Thursday. It's going to take you about 3 hours to write that. You need to plan for your party on the weekend and set up the music. You have a job interview that you need to set up, so you need to call Dave about that. And there's all kinds of details, and they've got to get that onto the schedule and consider all the relevant and irrelevant information and make sure they don't overlap things. And so it might take some changing if they read one thing first and put it in the schedule, and then they go back and read further down and something makes them change their mind on that. So it's a complex task. And for the adults, they're scheduling a work day. So similarly, it would be things like you have a meeting at 4:30, you have a disgruntled customer that wants to meet for lunch, you need to order flowers for someone that's important to you. So all kinds of things that they have to juggle the importance and the relevance and decide where that would fit on the schedule. Task 3 is making a decision. The S favors one, you decide on a gift for a classmate. So there's information about this classmate who has some disabilities and he's allergic to chocolate, and doesn't like loud noises. He's kind of awkward. So there's a list of gifts that you could purchase for him, and you have to decide on those gifts, on one gift. And then for the adults, you're deciding on a gift for a relative. So same thing, there's lots of information to consider, and it's very specific in there that it says choose only one gift.
And it's in bold.
It's in bold, and it is amazing how many of our clients miss that. They'll put yes for several of them because they can't decide. Again, that ability to differentiate relevant versus irrelevant information and attend to specific details and remember, if they don't look back at it, what they read, that it's very common for them to have errors. And if they put more than one, they get a 0. So right away that just really tanks their score, but it definitely shows the functional impairments that we see our clients exhibit, whereas those of us that don't have those challenges, we see that. We don't typically miss those kinds of glaring, bold things. We can, but generally not. Task 4, solving a problem. The S favors is the student is left home, the parents are out of town, which kind of doesn't fit for like a 12-year-old, because this goes down as low as 12. I wouldn't leave my 12-year-old home to be there when the TV man came, but that's what that task is. We keep thinking it could have been more related to solving something with school related, but anyway. And then the adult one is have a leaky roof, and the roof repair people are not responsive, and they lost the contract, and they now want more money, and they're being challenging to deal with, and then you have to write your response of what you would say to them and what you would want done. So that's organization, it's planning, it's working memory, and a lot of these do make them turn back and forth in the booklet, which taxes that working memory because they don't have it right in front of them. I've had only one adult in the whole time that I've done this that he asked if he could rip the page out so that he could lay it side by side, which showed some good problem solving, but most of the time they don't think of that. They just recognize they're overwhelmed, turning back and forth, but they don't know how to solve that problem in the moment. Some of the clinical interpretations that we look at with these favors and S favors is that the processing information skills that's required are relevant versus irrelevant information, weighing the facts. So once you have what facts are important, you have to decide what's more important than another, and that's a big challenge functionally that our clients have. Being cognitively flexible, which we've talked about a little bit before, those divergent naming things, and predicting. Predicting is difficult if you're not considering all the relevant information that you need in order to problem solve and predict what's going to happen next, or what may happen, or what you need to attend to. It gives you an accuracy score, which is how accurately you chose the item that was designated by the test to be the correct answer, and then your reasoning skills, which is how you reason through the answer that you chose. An important aspect with regard to time score, we do time it, but you tell them you can take as much time as you want. We just will be timing it to see how long it takes you. And the time score is important because if they have a high time score, meaning they finished it quickly, that can often indicate impulsivity, lack of attention to the fact that they need to slow down, or perhaps they didn't even read all of the information clearly and they just got overwhelmed and skimmed through it. And conversely, if they have a low time score, meaning it took them a long time, that can support the fact that they have impaired processing speed or poor time management, possibly visual challenges, that they're not able to read very well because they've got some visual challenges, and so that could take them longer to process through this. I really like the fact that with the the favors, there's a chart in the manual that gives a probability that their score falls within the ABI group. So basically it's saying it is maybe 95% probable that they have a brain injury, that they fall into that group because of a brain injury and not just because they maybe had a bad day testing or whatever. And so that really supports when we're trying to do maybe some of our work comp cases where we're trying to justify to the court systems that this individual really does have this brain injury and the testing supports it. One of the things I've always said when people say, well, I don't know, maybe I just didn't try hard enough. It didn't seem that important to me, so I didn't try that hard. And I always report that when I first got the favors, I wanted to give it to someone before I had given it to a client, and so I asked my husband if he would take the test for me, and he had a busy week, and I was just like, can you please just take this for me? I just need to see how it goes before I give it to a client. And so he sat down, and he's like, fine. Was not in a good mood about it at all. Whipped through section 2, which is the scheduling one, and that's the most complex, 100%. Right? So it demonstrates that when we do have these effective cognitive skills and our executive function skills are working, even in situations where we're truly not as invested or focused on it, we can still do well. So our clients that really have a hard time on these, it truly is because their brain is just not functioning as well as it did prior. The Schedule 2 task, which is the scheduling one for both the favors and S favors, they have research that supports that this is the best predictor for return to work. How they do on that task 2 really relates to whether or not people can return to work or not. And in the resource section at the end of our presentation, we've got the resource for I forgot their website now, CCD Publishing, I think, which is the Favors website, Sheila McDonald's website, and she has a link to some of those articles if you ever needed those to support how much this really reflects the functional challenges that people have.
Can we do the next slide? I don't have the clicker.
All right.
Switch spots. Okay, so like we had mentioned previously, the RBANS is another really common standardized test that we use for adults. And this looks at 5 different skills, so immediate memory, visual spatial or constructional, language, attention, and delayed memory. So for the immediate memory, that's broken down into 2 separate tasks. So the first one, you want to hold it up, Michael? The first one is a list learning task. So we provide them with 10 different words, and when we're all done, we ask them to recall as many words as they can remember. And you present that after 4 different trials. So ideally, you would like to see that with repetition, they're able to recall more information. However, a lot of times with our brain injury clients, it's just they're completely just wiped out, and they're not really making very much improvements. And then the story memory, that's where you present them with a short story. On Tuesday, May 4th, in Cleveland, Ohio, a 3-alarm fire broke out. 2 hotels and a restaurant were destroyed before the firefighters were able to extinguish it. And then afterwards, they're supposed to try and recall all the main details from that story. So again, if they're having a hard time with their memory, they're having a hard time processing information, that's going to be really taxing for them. We'll also see a lot of errors in their memory recall sometimes too, where they might say Thursday instead of Tuesday, or March instead of May, or just completely incorrect altogether. And then the figure copy, which Michael's holding up, so they're asked to copy that design in as much detail as possible. So again, that's looking at that visual spatial, that attention to detail. And oftentimes with our adults who have left neglect, we'll see that they completely miss all the details on the left side of the image. Or some clients who have some difficulty with their visual spatial skills, just the attention to detail will be completely off. And then the other one that looks at the visual spatial, this is the line orientation. So the 2 lines at the bottom, they're supposed to match up with the graph up top. So they're supposed to figure out what numbers on the graph above do those 2 lines match. Now, when I see difficulties with either the figure copy or the line orientation, that's a pretty good indicator that there might be some challenges in their vestibular ocular motor system. And that's one of those red flags that indicates they probably need a referral for physical therapy so they can get those issues more addressed. And then the language, so that looks at the semantic fluency. They're asked to list as many fruits and vegetables that they can think of in 1 minute. Like Michael had mentioned earlier, usually they'll get about 5 words and then they just completely shut down and just kind of that brain freeze. And then the picture naming, that looks at their naming and their word finding abilities. So you just show them some common objects and they're instructed to name them. And then for attention, there's 2 tasks for that, the digit span. So you give them a string of numbers and they're instructed to remember the numbers in the same order that you presented them in. And then the coding. So this is where they're provided with symbols and then they're supposed to match the numbers that are associated with the symbols above. So they're having to go back and forth, really having to kind of alternate their attention. And this, again, sometimes we'll see clients just miss several boxes or can be completely off with the symbols, so that tells us that attention to detail and the visual processing skills as well. And then delayed memory, that goes back to the 2 tests we did in the beginning, the list learning and story memory. So we asked them to try and remember as many of the words that we read in the very beginning. And then for the story, we asked them to remember the story about the firefighters as well. And then also trying to remember the design that we had them copy in the beginning. So the important thing to note here too with the recall and recognition. So if the client is not able to remember any of the words that were read in the very beginning, then that tells me that it's a recall issue. But the recognition portion, that's where I'll say, okay, well, was market on the list, yes or no? Was story on the list, yes or no? If they're able to get those well, then that tells me the information is being stored. They're able to recognize it, but they're not able to access it. So it's more of a retrieval issue rather than a storage issue, which is what we want to see. If it's a storage issue, then that tells us the information isn't even getting in there. This is more of a severe memory impairment. This is going to be a lot more complicated. I think I'd kind of mentioned on all of those before. Yeah. So, do you want to go back?
So we thought the timing was different. We thought we were starting at 9, and so we had a break set at a different time. So we're going to go on to the next section because our break, I believe, is at 10 o'clock. So we've got about a half hour more, and then we will take a break. I guess anybody have any questions at this point about the testing that we've done thus far, and or does anyone have any feedback of tests that they know of that they've found to be beneficial in working with this population?
I was just curious how often you retest for doing assessment over again. I know sometimes there's like a 6-month gap. You have to wait, or if you give that test, you can't give it again for a certain amount of time. So are these similar to that?
Okay, so for the online community, in case you couldn't hear that, the question was how often do we retest and how often can we use the same tests that we have? Because there are generally, I mean, the general rule is you wouldn't administer the same test for a year. But I think in the TBI population, sometimes that could be less because they can make significant progress and it would still show up on that. We did just recently get a second version of the R bands because we use that one so much, and we wanted to be able to retest sometimes more frequently. And when Josilyn does her case study that she'll share with you in a bit here, it really reflects why that is helpful to have. The S favors, there isn't a second version, and so you don't have that option to be able to administer a second version in order to test sooner. But generally, we wouldn't give that one within a year of giving it before, and or you would at least have to say there could be some factors here that they're remembering this information. But with a lot of our clients, that's part of their big problem. And so if we see them remembering it, that's great. They're using good strategies. So I would say that we don't do a lot of formal testing more than I wouldn't say sooner than 6 months unless the person made significant progress and we were looking at discharge and we wanted to do some more assessment to see how they're doing. But our clients, we often see for a year, more, forever. It depends on their situation. And again, the factors that we've talked about, if they have mental health challenges, that tends to really elongate the amount of time that we see them because we're working through so many of those issues with them as well and trying to set up tools and strategies. So kind of a roundabout question, I would say we do assessment at the beginning and then before discharge. And then if we're seeing them for an extended period of time, we might do in between. Or in the case of a student that I will share in a case study, I've done several assessments with him, but different things along the way. I haven't retested with the same test, but I've looked at other areas once it's like he's made progress in this area. Okay, now what other area do I really want to focus on? We did just purchase the test of everyday attention, which is, neither of us have even administered it to someone because I was trying to give it to my daughter and it was like, okay, I gotta look this over better because it's a pretty complicated one to administer, but we're hoping that that will help provide us with another test that will look more in depth at different areas of attention, including selective attention, alternating, divided. Any other thoughts on that when we reassess?
Yeah, I mean, I think I agree with all of that.
Anybody else?
Question? I have a question. Do you have a good parent questionnaire to kind of tease out if traumatic brain injury is a part of the history, because that is such a touchy subject. A lot of families are ashamed and really don't want to even talk about the trauma that happened.
Right. There's a couple different ones. The one that we've been using the most that we brought here today is the Cognitive Communication Checklist for Acquired Brain Injury, the CCCABI, and that's also from the Sheila McDonald's website with the favors and S favors. And by the way, we didn't say at the beginning that we don't have any financial disclosures. We don't get any kickbacks for mentioning any of these, but these are just the resources that we tend to use the most. And this looks at the auditory comprehension and information processing, expression, discourse, and social communication, reading comprehension, written expression, thinking, reasoning, problem solving, executive functions, and self-regulation. And it's very functional in that it will ask something like, do they have problems shifting their attention from one speaker to another? So the way they put it, it tends to, they just kind of think, oh yeah, yes or no. They don't think about it as, this says they have a brain injury. And so they're just kind of answering these functional challenges that their child might have. But it gives a lot of insight into what areas of functional life that it's impacting for them. And then, what was the one other one that we?
The Rossetti?
Well, the Rossetti for littles, you know, it kind of looks at their functional skills, but that doesn't really tease out executive function skills as much.
Well, and really for schools, in order to go with traumatic brain injury, we have to have some sort of a medical documentation. So I was thinking a questionnaire that a parent might feel more likely to share that, oh yeah, my child fell out of a second-story window.
Right.
He was fine. You know, we didn't have to spend the night in the hospital. Things like that that you can, you know, have something that you can tag that into a disability criteria. So they're not just ADHD or they're not just emotionally disturbed, but it's really...
Right. And generally, we would just ask the question, so have they ever fallen off a bike? Have they ever lost consciousness or even just had their bell rung in sports or, you know, any incidents that you can think of, even if it seems pretty minor, because sometimes that can have an impact. And I think when we focus on, if you look at some of the resources that we've brought here, if we just talk to them about, these are the things that could be impacted. So if you're noticing any of these and having them fill this out or just kind of talk about what are the challenges that they have. You know, if they're having trouble regulating their emotions, maybe it's because they're just cognitively overwhelmed and we just want to get them the support that we can. And so not focusing in on, you know, was it an abusive situation or whatnot, but just we want to get them the best support. And so if you can provide us with the challenges that they're having, let's focus on what we can do to improve those challenges, not so much on whether we're going to label them with a brain injury or whatnot. That kind of brings up an important point because often the kiddos that we see, at least, they may already have an IEP at school if they have co-occurring challenges such as attention deficit disorder or whatnot, but a lot of times they come to us and they don't have anything set up yet at the school, but they are struggling, and so we always kind of try and start with a 504 plan because that's less restrictive. They're mostly just getting some accommodations and getting some information to the teachers and other staff to know how to best support that student, but it's not necessarily going into a full-blown IEP. And especially with our high school and middle school, older middle school students, you mention IEP and they don't want that because they think of it as being associated with special education. And so going that route of a 504 plan, are you all familiar with what a 504 plan is? Mostly nodding heads, yeah. So if we set up that 504 plan, that can get them some supports, but not get into a full IEP with goals and whatnot. And sometimes we have to go that route if we're just not getting enough a high enough level of support with the 504 plan.
I was also going to say, I don't know if you brought the Seeds of Learning book that I showed you from Karen.
The which one? Yep, I think.
I think it's called Seeds of Learning.
Oh.
There's a clinician, Tara Sumter is her name, and she wrote this book, Seeds of Learning, and she works in a private practice, so she has a bit more flexibility in the schools, but she discusses how she targets executive functioning with all of her expressive language clients as well, expressive and receptive, and just the importance of targeting executive functionings to make sure that the children have the attention and memory information processing speeds.
Right, that's a great resource. Margot shared that when she was a student. So Tara Sumter, and it's Seeds of Learning. It's a pretty short little book, but yeah, she definitely talks about those executive function skills and puts it in a very positive way to be able to say how we could support them in everyday living situations. So that's a good resource. I don't know where that one is because I didn't bring it, but
Yeah.
should have.
I think some of it too, just to go back on that question, is also working a lot with the doctors. We get a lot of referrals for like ADHD or executive functioning disorder, but then when we look through the medical records, they'll mention patient has previous history of multiple concussions or brain injuries, but that was never an actual diagnosis ICD-10 code that they ever used. So a lot of it is having to work with the doctors too of, okay, well you mentioned this in your report, but you didn't include that as a diagnosis when that's probably the underlying issue here that's causing a lot of these challenges. So it's a lot of having to work with the doctors as well.
And I guess maybe
The mic for questions.
okay.
Thank you.
Just, I'll let you answer that in a second, but I think this is a good opportunity to talk about the coding and whatnot, because we get challenges all the time with the insurance companies that, for example, they'll say, if there's not a loss of consciousness, we don't cover it. Which is very challenging for us because that's the bulk of our clients, that they maybe didn't lose consciousness, but it doesn't mean that they don't have these impairments. And so trying to figure out how we can get other codes added in there or educate the insurance companies or get more research to support that, maybe it's the multiple TBIs is what does it. And so we need a ICD-10 code maybe that says if there's been more than 2 traumatic brain injuries, it should be included because there's likely going to be challenges in those areas.
I'm a school-based therapist, but I'm wondering if you've come across a way to gather baseline information versus prior to injury baseline information versus current functioning, because I've come across that in the schools where there's comorbidity of potentially a learning disability. But then the parent said, oh, but this many years ago, the kiddo fell, and hit their head. But like how to get at their baseline information, do you know?
That definitely is a challenging area because we often don't have very much information to say how they were doing before the accident, especially when there's comorbid issues going on that it's been attributed perhaps to ADHD, and maybe all along it's been more the traumatic brain injury. But I think we try and gather information from whatever resources we can get, neuropsych testing, schools, finding out how they were doing before in all of these executive function areas. And sometimes it's not a very definitive, yep, there's a definite difference. on testing, but we can say functionally maybe how they were doing. I can think of a high schooler that I had that she was on the trajectory for going through AP classes and going on to do well in college and not struggle, and both of her siblings did. So that was a comparison that we used too, that she had 2 siblings that had gone through all the AP classes and whatnot, and once she had her brain injury, she knew she couldn't meet those demands. She said, it's just too complicated, I just need to take the regular classes. And she did go to college, but of course lengthened trajectory to get through that because of all the challenges. So I don't have a great answer for that, but I would say to some level the impact testing that has been done with all the sports kids, that the school systems will put them through, that can give some information about how they were baseline if they didn't have any history of concussions beforehand, and then they retest them if they do have a concussion. So if that information's available, that's great to get a hold of. Anything else you have to say?
Yeah, I mean, I would just say like previous medical records, parental reports, talking to other teachers too. Have you seen a difference, in the kid post or pre versus post? So I feel like unfortunately there's not a clear, unless you saw them before, there's really no clear able to clearly distinguish the difference.
I do, when I have parents fill out that CCC ABI, I have them say, put down what you notice is a problem since their accident, or if it was a problem before, designate that it was a problem before also, so that we can look at the difference if they're saying it's just been since their accident versus, oh no, they've always had problems with this. And we hear that a lot even with our adults. Oh, I've always had a problem with organization, but now it's just exacerbated to the point that I'm not meeting my functional needs. Any other questions? Yes. Help you, by the way. Good.
It just seems like a lot of the evaluations, initial evaluations, you're relying a lot on auditory memory. Do you take into account visual learning, the different learning styles? For example, you may ask me to repeat a 7-digit number span. I can't do that. You show it to me for 3 seconds, take it away, ask me to repeat it, and I can do that. So how do you take the learning styles into account?
Yeah.
Good question. And one of the tests that I'll show you, I'm not sure how many of you are familiar with the test of information processing skills, the TIPS. It looks at the difference between visual versus auditory memory, and also ordered versus unordered. So for example, you show them letters, strings of letters, and they have to name those. You don't say them, you just show them, and they have to repeat them back, and the strings get longer. And then there is a question that you'll ask them that's also assessing, that is more auditory memory, that part of it, but that will say something like, please count from 1 to 10 in between, so that there's a short-term memory, and then you're taxing the working memory, both auditory and visual. And one particular client that I gave this to, actually 2 different ones that really stuck out. One that all of their auditory was clearly within normal limits, and all of the visual was clearly 1 to 2 standard deviations below the mean. So that indicated that they were definitely a visual learner, and they needed that. Did I say that the right way? They needed the visual information. Versus another client that all of their auditory was within normal limits and all of the visual was below normal limits. So that indicated they needed that information auditorily and not visually. So that's a really good test to look at that if we feel that's a challenge area. And on the R bands, there are some things that are visual and some things that are auditory, and the same with the favors and the S favors. Some of it they're reading and looking at, and other things you're asking them questions. And so we don't necessarily get a score that tells us that, but we'll be looking at that to say, do they do better on the things that they've read and looked at versus the auditory questions that we ask them, and then we could delve into it more with something like the TIPS test.
I got a question online. Someone said, do you know who is doing the impact testing in the schools, in Missoula specifically?
Are you still doing it? No. I don't know that they are. I know when my daughter was a freshman, they got tested. She's now a senior, so I don't know if they're still doing it, if anyone has freshman kids that they know.
It's a different test now, and it's on your phone, so it looks at some visual motor stuff.
Okay.
Okay, so she says it's online now that they do in town, and you don't know who does it?
I know the athletic training department at U of M is working to have a more standardized impact testing throughout the whole school system. We had somebody come and talk to us.
So the athletic department at the University of Montana is working on having a more standardized measure for the high schools in this area. I don't know, does anyone know what else is going on anywhere else in the state?
I'd say the peak performance physical therapy is doing a brain health assessment that looks closer at the vestibular system, ocular motor system, balance, reaction time, dual tasking. Not quite as much at these skills here of the attention, memory, concentration.
Definitely something that's needed, though. And I think that was a great idea to have those incoming freshmen be tested, because then if there are concussions that happen throughout their years in high school, then they have that baseline testing, which is critical, and we just don't always have it.
Yeah, and I think, well, he's gone now, but to address his question of the auditory versus visual, we'll dive a little more into that in the treatment portion about how we target the person's ability to process information, whether that's visual information or auditory information. So we can kind of dive more into that here in a moment. So do you want to go in?
Yeah, I guess we can. Yeah, we'll go on. We'll go on a little bit. Hopefully this won't make it too disjointed, but just kind of starting to talk about the treatment focus for children. We really want to make sure that we advocate for academic accommodations that they might need, and I talked about that a little bit, but in initiating a 504 plan, or if they needed an IEP, and make sure that our goals are based on their academic and client and parent and caregiver concerns. So we talk a lot in our notes about patient-centered goals, that we want to make sure that we're including them in the process of what's going on. So we might test and say, this is what the test showed. The test showed that you're having problems with attention and with memory, but they say, my biggest problem is this, and I really want to fix this. And it might be somewhat related, but so we want to make sure and take their information into account when we're developing those goals. Facilitate their ability to organize their schoolwork, so a lot of work with planners and getting them started on using advanced organization systems that are going to help them to be able to plan, pre-plan, follow through. Facilitate their ability to manage the systems that they're using in the school, such as Google Classroom. That was really big when there was all the online schooling. Pretty much everything was the Google Classroom, and a lot of our clients had just a really difficult time doing everything online and not having the structure of the classroom and having to try and find things, especially if there are those visual impairments, them trying to scan their computer to find where is that Google document that I need to be able to turn in. And I'd have clients that be like, there isn't a place to turn it in. And when I'd get on with them, it's like, do you see that right there where it says turn in? And you click on that, that's how you submit it. So those challenges in helping them to be able to navigate the systems, and the MCPS, for example, just switched over to Infinite Campus from Q Portal as the system that the kids can use to get on and check their grades and see what's missing. And so we'll work a lot with them on trying to organize that information and find what's missing and make a plan for being able to turn their classwork in. Planning for upcoming assignments, homework, tests, as I just kind of talked about with the Google Classroom or with their Infinite Campus to know what they need to do, and then also those paper planners that we find those to be so critical that they have the paper version to be able to look to. facilitating the children's ability to communicate successfully with their peers, family, and teachers. That's a big challenge area for the clients that we see, because we'll have teachers that, and this is nothing against teachers, I think they do an amazing job, but there are times when they don't understand it as well, that they'll say, well, they just need to ask me for help when they need it, and I'll be happy to help them. They don't recognize when they need help or how to ask for it. They may recognize, I'm struggling, but they don't know how to say, I get this part, but I don't get this, I need help with this. Or, they just need a lot of help from us to facilitate, how do I even use those clarification strategies or use my tools to be able to get help from my teachers or parents or coaches or whatnot.
And then the primary focus for adults, so a lot of what we're doing, we kind of touched on earlier, is advocating for the correct diagnosis and insurance coverage. Like I had mentioned, oftentimes the initial diagnosis that the doctor sends us with is not necessarily always accurate, or what the primary diagnosis or issue that's going on. So trying to really work with them on that. If they are in work or having to take time off work or want to re-enter into work, we're working a lot with coming up with work accommodations for them that will set them up for success. Also facilitating in the application process for the SSDI services. If they are unable to return to work and are needing to get on the disability services, that application process is very complicated, and oftentimes they're really needing a lot of assistance with that. Or even just the job searching process too just seems to be very taxing for them, so helping them kind of plan and problem solve and navigate that. Or if it's a student going into college, helping them set up the DSS. I think they just renamed it here at the U of M. But the disability services application for college students, so that they're also getting the accommodations they need. Medication management is often a big one for our folks, especially for those with memory impairments. They might not remember if they already took their medication. They might overtake medication, which could create some serious safety issues. They could overdose, and so making sure we're setting them up for success and really addressing those safety concerns. Another really big thing that we do, I would say almost every single session, is facilitating in their metacognitive awareness of their specific diagnosis and their associated challenges. I think that knowledge is power, and so when you can educate your client on what's really going on and let them know that it has nothing to do with their intelligence or their competency, but it's just that their brain has been through so much, and really helping them understand that is going to be huge in their prognosis and their recovery. Also similar to that of the children, helping facilitate in their ability to successfully communicate with their friends, family, health professionals, coworkers, or just people in the community. So oftentimes we will help them kind of pre-plan for conversations. So instead of just entering into that conversation and having no idea what to say, they've already kind of come up with a plan and thought that through so that it's not as overwhelming or demanding when they're in that situation. We might also write some social scripts to help them kind of walk through that process and be able to communicate effectively when the time does come, especially for folks with memory challenges or word finding difficulties. Those can be really helpful, or social pragmatic difficulties as well. And then also educating them on the word finding strategies, that when you know what you want to say but you can't get the correct word out, instead of just sitting in silence, how else can you kind of navigate around that and help communicate more effectively. Again, the treatments are focused on patient-centered goals as well as family or caregiver concerns. And then another thing that we have been implementing, which has been extremely successful, you've been doing some with the kiddos, I think, too. But setting them up with a cognitive communication binder. So what we'll do is right after their initial assessment, based on the primary skills that they're having difficulty with, so let's say attention, memory, processing information, and regulating emotions, those are the 4 primary issues they're having difficulty with. We will then set them up with a cognitive communication binder that is organized by those 4 primary skills that we will be addressing during our treatment. So that way, anytime we go over any resources, any strategies, any tools that they have found to be successful, we'll put that in that section. So if we're working on attention, we'll put in those attention resources in that section of their binder. And they take that binder home with them and they bring it back every session. So that's been really helpful to facilitate in the generalization of the learned skills, especially if they have memory difficulties. They might not even remember what you talked about the week before. So if you can say, oh, well, let's look in our binder and let's review, what we talked about last session, just that repetition of them seeing it, like you had mentioned, that visual learning of them seeing it and visually being able to go over it that multiple times can help. It can also help educate family members. We use we had mentioned in the beginning, we have a folder that everyone has access to of a lot of the resources we put in those binders. The resources are also up in here. There's a lot of education of what brain injuries are, what some of the common symptoms are, so that family members also can understand it better and not take some of those things as personally. And then another thing we've been doing is having a final presentation. So having the patient kind of recap everything that has been discussed in our time together. And so 4 main concepts that we usually have them target is, number 1, what happened to me? How did that impact my brain? Whether that was a non-traumatic or traumatic brain injury or learning disorder. Number 2, what skills were impacted as a result? Number 3, what specific strategies can I implement for each skill that was impacted? So what specific things can I do to improve my attention? What specific things can I do to improve my memory? What specific things can I do to help me regulate my emotions? And then the 4th concept is, what are the considerations I need to take into account going forward? And I'll kind of show you a case study later on of what that looks like. But oftentimes we've been doing that as a presentation, and that's been really helpful as a clinician. Helps me know whether or not I'm confident to discharge this client. Because if they show very poor awareness or understanding, they're probably not going to do very well if I just let them off. But if they can tell me that they're really grasping it and they really have a good understanding of what tools and strategies they can implement, then they're probably going to be pretty successful.
I think actually it's just a couple minutes before 10, so we'll see if there's any other questions. And then I guess I'm not sure, when's the break go until, Michael?
It's 15 minutes.
15 minutes, okay. So back at 10:15, and we'll continue on with the rest of it, and then we go until, I think, 11:45, I believe.